antimalarial drug classification. Okay, see here, first write 4 A's, 4 times A, then what is after A? B, then what is after B? C, then what is after C? D, and after D write directly Q, N, N and S, S. What we are doing? We are writing A, B, C, D, Q, N, N, S, S. Here in front of our first A write 4 and second A write 8. And now follow the code for drugs, that is first write queen, again write queen, again write queen, again queen, again queen, again queen. 6 times you have to write. Okay, after writing queen, here write cap PTM. From starting it is chloroquine, amodiaquine, piperaquine, primaquine, tafenoquine, mefloquine. Here first we have this 4 A's, right? So take this 4 A near these 3 drugs. This is the first class of drugs. This A represent 4 amino quinoline, and this 8A is for this 2, that is primaquine and tafenoquine, and this mefloquine goes with this Q. What are the abbreviations of this? Here this is 8 amino quinoline, this is same, this number is changing, and this mefloquine is for Q, that is quinoline methanol. Okay, for this we have mefloquine. Okay, what we finished 4A, 8A, Q, and this 2A stands for, one is for antibiotics, that is clindamycin, and the second one is doxycycline. Okay, as these are most widely repeated in our pharmacology sessions, you can remember this clindamycin and doxycycline for this 3rd A. And for 4th A, it is amino alcohol, that is lumefantrine. Okay, this A also we complete. For this B, it is biguanide, it is proguanil. See, this is single drug, this is single drug, right? So make sure that you don't forget these names, because these are in order. I had told this mnemonic, but for this if you keep mnemonic you might confuse with other drugs. So biguanides, it is proguanil, and for amino alcohols it is lumefantrine. Here what we finished? B we finished, all A's we finished. Okay, then we are going with C. In C we have cinchona derivatives. In the cinchona derivatives we have, see, we are seeing quinoline, queen, right? So write quinine. Okay, then write for this quinine, write dine, quinidine. Easy, right? We finished C also. Then for D, go with diaminopyrimidine. In this diaminopyrimidine, take this pyr and write pyrimethamine. Okay, in diaminopyrimidine, take pyri and write pyrimethamine. And we finished D also. We have 2 N's and 2 S. So for the first S, write sulfonamide, sulfonamides. Here for sulfonamides, the prefix will be sulfa only for the drugs, that is sulfadoxine and sulfamethopyridine. Okay, we are starting with sulfa only, sulfadoxine, sulfamethopyridine. Okay, we finished S, and one more is S is for, first don't write S, write quaterphenylactone, and then write cis quaterphenylactones. Why I am telling quaterphenylactones? Because it is like some name, right? Quaterphenylactones, like okay, I personally remember Harry Potter when I pronounce this word. Okay, that is quaterphenylactones, and add cis quaterphenylactones. So here you have to write artemisinin derivatives. Those are artemether, artether, and for it add dihydro artemisinin. Okay, we finished 2 S's: artemisinin, artemether, artether, dihydro artemisinin. And now I will write this 2 ends. Okay, I will write this this antibiotics and amino alcohols. For the first 10 you have naphthyridine, and for the second end you have naphthoquinolone. Wait, I'll write the spelling correctly. Naphthoquinone. Here naphthoquinone. Here we have, in the ending write on, and this dine only again right here. Here we have atovaquione, and here we have pyronaridine. Okay, see, first I am writing naphthyridine and naphthoquinone. Here I am taking on this from ending and dine from ending, and I am writing pyronaridone atovaquione. This is overall classification of antimalarial drugs. In the next session we will discuss about chloroquine and artemisinin. They are very important drugs in the antimalarial drug classification. Now we are going to discuss about chloroquine. See, here before discussing about chloroquine I will tell, sporozoids first are transmitted to our blood while the mosquito takes the blood meal, and these sporozoids reach liver, and after that they form schizoid, and then they form merozoids, and then this merozoid enter the RBC and transform into ring shape, and then to trophozoid, then they form erythrocytic schizoid, and then it will again form merozoites, which will infect new RBCs. Okay, here while this RBC is being broken to release these merozoids, what happened? Along with this RBC material, inflammatory mediators are also released. So that is why we are getting fever. Okay, along with whenever the RBC is bursted to release the merozoites, there will be release of inflammatory mediators also. There is because of this only there is fever. Here see, in this porozoites to liver, schizoid and merozoite will have no symptoms. Only from here whenever the burst is taken will have the symptoms. So we are using chloroquine in this RBC erythrocytic stage. Here I will tell one more thing. In this parasite there is food vacuole, right? In the food vacuole it will break hemoglobin to heme, but actually this heme is very toxic that it might also kill this parasite, but it is not been killed. Why? Because it transferred this heme into non-toxic substance to protect itself, that is hemozoin pigment, hemozoin granules or hemozoin pigment. This hemozoin is non-toxic to this and it can be prevented from death from heme. So our chloroquine will go and stop this heme to hemozoin conversion. That is, chloroquine stops the polymerization of heme to hemozoin granules or pigment, and it will kill the parasite. Here the toxic heme is being accumulated and the parasite will be dying. So this is the mechanism of action of chloroquine, that is stops the polymerization of heme to hemozoin granules. Because heme is very toxic to the parasite, it converts heme to hemozoin pigment or hemozoin granules. So we are stopping that step and making the heme to make it die. Okay, we understood the mechanism of action of chloroquine. Now we'll discuss about the therapeutic uses and also adverse effects and also contraindications. See here, therapeutic uses we can anyway use for Plasmodium vivax, Plasmodium ovale, Plasmodium malaria, and sensitive strains of Plasmodium falciparum. See, why this Plasmodium falciparum is resistant to this chloroquine is, before I told that in the mechanism of action this heme is being converted to hemozoin, so we are stopping that by giving chloroquine. But to show its action it should enter the food vacuole. So what in this Plasmodium falciparum, what happened, this food vacuole have special efflux pumps. If this chloroquine enters also, it will send it out through this efflux pumps. So this is the mechanism of resistance of some strains of Plasmodium falciparum. So in therapeutic uses, only sensitive strains of Plasmodium falciparum can be affected through this chloroquine. And then we have extraintestinal amoebiasis. Why? this drug goes and accumulates and concentrates in the liver, so that it can also be used in amoebiasis, extraintestinal amoebiasis, and it can also be used in discoid lupus erythematosus. What is this discoid lupus erythematosus? That is, if this is the face, in the ear region and in the cheek region, there will be coin shaped rashes which will aggravate on which will aggravate when light falls on them, and these are scaly lesions, and if you peel the skin off, there will be pink color area, like it will be appearing. Overall it will be coin shaped, so the name discoid came. Discoid lupus erythematosus, we can use, this is an autoimmune disease. Okay, we can use this chloroquine, and some photosensitive reactions also we can use, extraintestinal amoebiasis, and we can also use in other rheumatoid arthritis due to its anti-inflammatory action. Okay, we are done with the therapeutic uses. We will go with adverse effects. See, if this is a person, here this chloroquine will go first into eyes, into retina, and into cornea, and they will go into muscles, they will go into skin, they will go into heart, they will go into heart. Okay, and then they will go into peripheral neurons. These are all the ADRs. I will explain one by one. In the eyes, they might cause blurring of vision. Why? Because this chloroquine might accumulate in the retinal pigment epithelium and cause blurring. So retinopathy, and it might also deposit in corneal depositions might also be seen. Okay, we finished the eyes part. Then we are talking about this muscle. It can cause myopathy because it enters the lysosomes. Okay, lysosomal in them, and it can cause myopathy. And in the neuromuscular junction, it can also cause neuromuscular junction abnormalities also it may cause. And in the skin, it might cause pruritus. Why this pruritus? Whenever it is under the skin, it will start histamine like pathway, and it might cause skin inflammations. So pruritus. We finished the skin, this muscle, and this eyes. And in the heart, it might there are conduction impulses, right? These conduction impulses will be altered, so he might land up in arrhythmias and hypotension. Okay, we completed heart also. In the peripheral neurons, he might land up in peripheral neuropathy. Okay, this is also finished. And one more we missed, that is in the circulation, rarely he might have bone marrow suppression, and overall in common he can have nausea and vomiting. And in the brain, in the CNS, related to CNS, not in the brain, related to CNS, he might have headache, and also dizziness. What are we covered? We covered from the top headache and dizziness in the CNS, and in the eye it causes blurring of vision, retinopathy and corneal position, and then in the muscle it might cause myopathy and NMJ dysfunctions, and in the heart, okay, we'll complete the hand. In the hand, under this, not in the hand, under the skin, in the skin, anywhere in the skin, it can cause pruritus, that is by evoking histamine like pathways. It might cause the skin irritations, inflammations, and it is more commonly seen in Africans. Okay, and here in the peripheral region it can cause peripheral neuropathy, and in the heart, due to disturb in the impulses, it might cause arrhythmias and hypotension, and in the blood it might rarely cause bone marrow suppression, and in common the patient might suffer with nausea and vomiting. Okay, these are the adverse effect. And what are the contraindications? The person with previous any retinal impairment or any eye related problems are contraindicated from this drug, and that is the thing. We'll discuss about one more drug, that is artemisinin. See, remember first one thing, that is this artemisinin is never given alone. It is combined with some other antimalarial drug. We'll also know about artemisinin based combination therapy in the end, but now we'll know about the mechanism of action of artemisinin. In the artemisinin, there is a special structure, that is endoperoxide bridge. Okay, this is the endoperoxide bridge. This endoperoxide bridge, whenever it is encountered with ferrous form of iron, it forms free radicals, carbon centered. Whenever this endoperoxide bridge comes in contact with the ferrous form of iron, it forms free radicals which are carbon centered and highly effective. What happen? This, whatever the RBC stage is there, whatever the stage of parasite in the RBC, it will be killed. How? You can directly write that there is an endoperoxide bridge. When it reacts with the ferrous form of iron, free radicals are produced and it will be killing the parasite. Or else, if you want to write more keenly, you can write SARCA, that is sarcoplasmic or endoplasmic reticulum calcium ATPase. These free radicals go and disturb this. Due to this, the calcium homeostasis is disturbed and the cell will eventually die. What happened? In our drug artemisinin, we have endoperoxide bridge that will react with the ferrous form of iron. Free radicals are produced. This will act on the SERCA, which impairs the calcium homeostasis and eventually kill the parasite. So where this ferrous form of iron is coming, you know that this will be consuming the RBCs, right? Hemoglobin. By breaking it down, it produces ferrous form of iron. So after producing this ferrous form of iron by the parasite, this and this drug will combine. Okay, so that any stage of erythrocytic stages of this parasite will be killed, like ring form, Schizon form, anything will be killed. But to kill the liver forms, that means hepatocytic stages, we have to use some other drugs like Premaquine. Okay, that I will tell in the ACT regimen. But now you have to remember that there is an endoperoxide bridge which interacts with the ferrous and generates free radicals and kills the parasite. Okay, this is highly effective, very very highly effective, more than the chloroquine. Rapidly acting, artemisinin are rapidly acting. They have short half-life. See, therapeutic uses we can use in uncomplicated Plasmodium falciparum. What is uncomplicated falciparum? That is symptoms like chills and fever and shivering is there, but more complication like severe CNS symptoms are not there, like very dizziness, that much are not there in the. If they are not there, it is called uncomplicated. Only fever is also there, that's some 39 degrees to 41 degrees, but the CNS symptoms are not much included, so it is uncomplicated. We can use artemisinin. Then in serious Plasmodium falciparum also we can take IV or IM artemisinin, and also we can take in chloroquine resistant Plasmodium vivax or Plasmodium falciparum. Okay, these are the therapeutic uses, and adverse effects also I will tell, and then I will tell about the ACT. Now the adverse effects. First one, the spleen will be, first there are the parasite in RBC, right? This artemisinin will kill these parasites, and spleen will clear these RBCs. But during this action, there will be some sort of distortion. There will be some sort of notch-like formation, due to which spleen will clear, but it will be delayed. Delayed hemolysis. Okay, I will here write delayed hemolysis. Post artemisinin therapy, we can see this delayed hemolysis. In the cardiovascular system, we can see QT prolongation. It is also mild, and it is also due to the partner drug, not due to the artemisinin. In the starting I told, right, artemisinin is not given alone, but due to the partner drug which is added with it, QT prolongation might be seen. And general symptoms like nausea, vomiting, CNS symptoms like dizziness, headache, tinnitus can be seen. Okay, these are the adverse effects. To tell about ACT regimen, that is artemisinin based combination therapy. Okay, to remember this, first write. Okay, I will erase this so that we can get space. Write artesunate and artesunate for 4 times. Now here we add with mefloquine, we add with sulfadoxine plus pyrimethamine, and here artesunate plus amodiaquine, and here artesunate plus lumefantrine. Okay, here the dosage is artesunate is 80 mg plus lumefantrine is 480 mg BD into 3 days. Here the patient should be advised to take with fatty meal. Why? There will be better absorption. And here there is one more thing, the combination tablets of this, in the combination it will be coming with 20 mg artesunate plus 120 mg lumefantrine. This is the combination drug. This one you can take if the adult or child is more than 35 kg, you can take 4 tablets per day, and if he is from 25 to 35 kg weight between, he should take 3 tablets, and if he is 15 to 25, he should take 2 tablets, and if he is 5 to 15, he have to take 1 tablet. These are the combination tablets. These are the weight in kg. Okay, and then we finished this one. And now coming from the bottom, here this one and in this we have to give 100 mg BD, 100 mg twice daily. Okay, BD is nothing but twice daily, and here artesunate it is 200 mg. Okay, then mefloquine, this is on the first day. On the second day, 750 mg on second day, plus on third day he should be given with 500 mg of mefloquine. And then here sulfadoxine it is 1500 mg plus pyrimethamine, it is single dose, it is 75 mg you can give. And here amodiaquine, it is 600 mg. Okay, this is also BD to 3 days. Okay, this is the ACT regimen, that is artesunate based combination therapy for treatment of uncomplicated Plasmodium falciparum malaria. Okay, this is the thing. Thank you.